workroom where you go to, type your notes in between or where you're looking stuff up. We have, and in fact we have several of these charts just hanging up in our workroom so that our medical students and our residents have that as a reference, especially like the drug, what's considered low, medium, and high dose for all the different age groups. We have those charts all just hanging up. Yeah. I wouldn't expect anybody. Now, if you're going to take this certified asthma educator exam, you have to have it all memorized, but otherwise it's an easy thing to reference. Yeah.
So if you're debating between two levels and go with the higher and the patient comes back and their symptoms are under control, would you then want to put them one step lower to see
So
if...
on that assessment of well-controlled, not well-controlled, poorly controlled, if they've been well-controlled for 3 months or more, then it's reasonable to consider stepping them down. So you go back right through that
And just
chart.
do that every 3 months until...
Exactly.
Okay.
Yep, and if they're well-controlled, and you may get them down to really low-dose therapy, and this happens to some of our patients too, they're on the lowest dose, and you're like, okay, so then your only option from that is to go off. But you want to follow them really closely. If you've weaned them down to, now you're weaning them to intermittent, and make sure that they're really well educated on how much symptoms is too much. And there's something called the rule of twos. Baylor has it trademarked, so I can't put it in my slideshow, but the rule of twos is daytime symptoms more than 2 days a week, or nighttime symptoms more than 2 nights a month. And so it doesn't really go for the 0 to 4-year-old category, but it's a nice kind of easy rule of thumb for patients to remember too. If I'm having symptoms more than that, my asthma's not under good control. So whatever change we made last time, that's not working. And even then, before their follow-up visit, then they need to call back and go back up on the dose if that was the case. Or if they had stopped an inhaled steroid, they may need to start it back. That makes sense. So that's a good question though. Great question. So each time it's like you're coming in, commit to me how much coughing, wheezing, how much albuterol. I'm going to put you on the chart. Okay, you're here. We can leave you where you are, or maybe go down. Or oh no, you're here. You're not well controlled. We need to go up. First, I probably need to check and see if you're actually taking your medicine. If that's really the issue, and what I would say is the vast majority of the time that's the case. All right, are we ready for medicine? And then a break after medicine? Yes? Okay, fantastic. So when it comes to asthma therapy, one you can see just by the spray that I brought here, spread, is that there's a lot. But what patients and providers especially need to understand is there's basically 2 categories. There's controller medicines and then there's quick relief medicine. Everybody's pretty familiar with quick relief medicine. It's on Goonies. He's taking his inhaler. You're pretty familiar with that. But the controller medicines, and making sure that they know the difference between those 2 things, because they're 2 vastly different things, is really, really key. And making sure that a patient knows the difference between their one they take every day and the one they take as needed, and that they know the difference in the colors so that they don't accidentally go, oh, I just came in from running and I need my rescue inhaler, and they use their inhaled steroid, which will not provide them any relief. So really important they know the difference for that. And that's why also too I said the pictures and all that is so important. So when it comes to, and we kind of touched on this just a little bit, most asthmatics don't require daily asthma therapy. True or false? What are your thoughts? False, right? So when they actually look at symptoms, severity, the vast majority, that blue, that brighter blue section, that's moderate persistent asthma. So those are folks who are on at least moderate dose, medium dose inhaled steroids. So the vast majority of asthmatics, if they're really honest with how frequently they have symptoms, the vast majority are going to fall into that moderate persistent category. That little, the light blue is the intermittent. So the smallest category is the group that only needs a rescue. The next one up from that is the mild persistent ones that might be okay on a low dose inhaled steroid, and then the purple are those severe persistents, and those are the ones that are generally managed in specialty care. Okay. So controller medicines, most asthmatics need them. Most of them are in denial about the fact that they need them. A lot of providers and prescribers are in denial about the fact that they need them, but most of them, if you really ask the tough questions, most of them are going to meet that criteria. So they maintain control, they prevent exacerbations, they're taken daily regardless of symptoms. You don't tell somebody with hypertension, here's your blood pressure pill. When you feel a lot of headache and your nose is bleeding, take your blood pressure medicine. No, you take your blood pressure medicine every day to prevent those outcomes. All right, so the things that fall into that long-term controller category is primarily inhaled steroids, ICS, inhaled corticosteroids. always gonna be the right answer when it comes to what's the mainstay of asthma therapy for control, inhaled corticosteroids. Long-acting beta-2 agonists, so there's long-acting types of, like albuterol, long-acting type of albuterol is used in addition to inhaled steroids in some patients in those higher, like step 5 and 6, some 4, depending upon their age. Combinations of those two. Leukotriene modifiers, you may be really familiar with Singulair, Montelukast. It's a pill, so it's real easy to take. But it is alternative therapy for control, and so it's adjunctive, maybe in addition to, it may be they're on an inhaled steroid and that. Immunomodulators, like Xolair, it's an injection, it's a once a month or twice a month thing that is generally only managed in specialty care. Cromolyn and Nidocromil are very old and really not used much anymore. I imagine the next set of guidelines, they may take them out. If some of the old guys that are on the guideline committee finally retire, I bet those things will not be on the list for the next time. Sustained relief methylxanthines, this is like theophylline, which is what I took as a kid. It's horrible. You have to do blood level, you gotta do check blood levels on it, and it makes you feel just terrible. It's just systemic. I mean, it's systemic and you feel all the time. And then oral steroids. Although oral steroids are also quick relief, right? During exacerbations, you get an oral steroid. But oral steroids, for those who are the most severe, step 6 therapy, some patients are on oral steroids for long-term control on a long-term basis. So there's the inhaled steroids, long-term prevention, suppression, control and reversal of inflammation, reducing the need for oral steroids. It's actually shown to really benefit and allow the beta-2 agonist to work better. Someone who's on just the beta-2 agonist, just the quick relief, those receptor sites, there's the risk for those receptor sites being used up, and so being on an inhaled steroid actually makes those receptor sites more receptive, so it's better in that regard. Reducing hyperresponsiveness and all the other pieces of that inflammatory cascade that I'm not going to even attempt to explain, other than that there's a lot of factors involved, the cytokines, and the inhaled steroids is really kind of blocks that whole cascade. So there's a lot of choices. Some of them are newer than others, but a lot of them have been around. I mean, we have some that will probably be going generic sometime soon, we hope, because some of them have been around a couple decades now. Qvar, things you may have heard, Qvar, Pulmicort, Alvesco, Aerospan, Flovent, Asthmanex, Asmacort. So there's lots of different options. And they come in lots of different forms. They come in metered-dose inhaler spray kinds, they come in dry powder kinds, different types of dry powders. There is one that is available nebulized as well. So there's lots of options as far as that goes. And these are the estimated comparative dosages, and that chart is here in that reference. That you are linked to that reference in your guide. And this is, like I said, this is one of the ones that we have hanging up in our clinic even, to say when you get to that part of the chart that it says, for this 5-year-old, you need a medium dose, okay, well, what's considered medium dose at that age? And this will tell you. You just go from one chart to the next, It's so easy. All right, inhaled steroids, kids. True or false? Inhaled steroids stunt growth in children and should be avoided. Thoughts on that? False. See, you guys are doing good. These are all common myths. So there is an effect on growth, but it doesn't mean that we shouldn't use inhaled steroids. So poorly controlled, we know is really poorly controlled asthma. Those kids don't tend to grow well either. The pretty extensive studies have been done looking at long-term use of inhaled steroids, and what we found is in the first year at a low or medium dose, there seems to be an effect of growth velocity by about 1 centimeter. So growth velocity, the rate at which they grow. In that first year that they take a low or medium dose inhaled steroid, it may affect the growth velocity by about 1 centimeter. But when they look at it long-term and they compare like predicted adult height, which you calculate by parents' height, and when they look at it long-term, it's not a cumulative effect. It's not that every year you're on it, you lose another centimeter, or you don't grow another centimeter. But it doesn't seem to affect the final adult height when it's predicted that way, and when they look at it long-term studies. And they have studies now that are looking at folks that have been on it for multiple decades. And so in general, yes, it may slow your growth a little bit at first, but even if you continue on a lower medium dose, it's not a cumulative effect and not a permanent problem. And higher dose is certainly at a little bit greater risk, and that's why I mentioned in asthma visits, height is one thing, and I know some of our patients are just like, it's the lung clinic, why do you guys always want to measure me? But that's certainly one. And some of our patients on the highest dose, or those who are on orals, we get endocrine involved with them as well, as far as adrenal suppression and growth concerns for those higher risk patients. But the low or medium dose are generally considered really safe. Even high dose inhaled steroids have a much less effect than orals. So if you've got a kiddo some providers for some reason are just scared of inhaled steroids, but they'll give them oral steroids each time they see them, which is really strange to me. You're seeing them for the third or fourth time this year and giving them oral steroids, but you don't give them an inhaled steroid. The effect of oral steroids is certainly far greater, and it is a cumulative effect over time. Using a holding chamber minimizes the side effects, so you get more in your lungs and less deposited in your mouth. You have much fewer side effects that way. And any children that are on high doses, those are kids that fall into that higher risk, that severe persistent category that should be managed by a specialist anyway. So when it comes to, questions about inhaled steroids, it will be the right answer. If there's a question about what is the preferred treatment for long-term control, inhaled steroids. Inhaled steroids for persistent asthmatic inhaled steroids. So long-acting beta-2 agonists can be added to inhaled steroids. So it's a longer-acting type of bronchodilator. It's not indicated for monotherapy, so it should never be on it by itself. It's in addition to inhaled steroids. And in fact, there's a black box warning that's probably going to be removed sometime this year based on some newer studies that are out, but about using long-acting bronchodilators by itself. But fortunately, they're available in combination with inhaled steroids in the same inhaler, so you don't have to worry about that. Yeah?
Does that same research also include oral steroids, or is that a different?
As far as looking at
growth rate or growth velocity?
So that is, those growth velocity studies, those are inhaled steroids. So certainly kids who are on oral steroids are much more at greater risk of growth suppression.
Okay.
High dose inhaled steroids or oral steroids, much higher risk. And those are the ones that are generally managed in specialty care, and often they're followed by endocrinology too. Yeah. Okay, so the examples for long-acting bronchodilators, Ceravent, Fordil, Performist. Like I said, they're available in combination with the inhaled steroids, which is good because that's the only way they should be given. And they come both together in the same device. So we're going to talk about a few of those. There was some controversy. Like I said, there's been some new data just released on the 6th of March to say that they're probably going to remove this black box warning. But there was a study in 2006 comparing long-acting bronchodilator compared to inhaled steroid. And those who were only on the long-acting bronchodilator had a pretty significantly greater risk of severe outcomes. And so that's where they put the black box warning there. What they found is when they compared it to those who were using it with an inhaled steroid, the risk, it was considered to be very safe in newer data. So certainly I would never recommend using an inhaled long-acting bronchodilator alone. And so that is contraindicated to use it alone. But in combination with inhaled steroids, in general, that is considered to be safe in combination. So this has a whole discussion of those studies. Big meta-analysis looking at a whole lot. So they're not indicated as first line, not indicated as monotherapy like by themselves, not for somebody who's well controlled on another, and you hear it on all the commercials. This medicine's not for somebody who's well controlled on another therapy. So if they're well controlled on an inhaled steroid, there's no reason to give them a long-acting bronchodilator because that's going the steps. They should be advised of the risks of worsening asthma, and that's a big piece of your education anyway. So there are several that are available in combination, Symbicort, Advair, Dulera, and they use different inhaled steroids combined with the two different long-acting bronchodilators. Okay? And those you're probably pretty familiar with. They advertise on the TV all the time. Leukotriene receptor antagonist I mentioned, Singulair, Montelukast. So it's a pill, which just makes it easy. A lot of primary care folks love to just hand it out. It was more recently approved for treatment of seasonal and chronic allergic rhinitis. So a lot of people, they're like, I don't know, do they really have asthma? I'm not sure. They seem to have allergies. I'll just give them Singular, kill two birds with one stone. Well, if you really think they have asthma, and persistent asthma, if they meet that step 2, the preferred treatment is still an inhaled steroid. Not to say that Montelukast or Singular is bad, it's just not as potent and not the preferred initial treatment, maybe an adjunctive too. But it does provide long-term control. I have my patients tell me that it helps them tremendously with their allergies. When we stop it, when we're weaning their asthma therapy and we're going down on the steps and we stop it, they'll call back saying, oh, my asthma's fine, but man, my nose is so stuffy since I stopped it. In which case, I let them start it back again for that purpose. So it is approved for both. Singular Accolade is the other one. It has some dosing issues with meals and not with meals and timing, so it's not used near as much. The nice thing with the Singular, it comes in little chewable tablets and stuff, which makes it easier for kiddos. So that's your leukotriene receptor antagonist. Anti-IgE antibody, this is the injection Xolair, omalizumab. It binds IgE, so IgE is the immunoglobulin that triggers that big inflammatory response, right? So this binds up the IgE, and it is a monoclonal antibody. And it's very, very expensive. It's only it's a step 6 kind of a treatment. You have to have really proven yourself by monthly refills of your high-dose combination therapy, pretty severe asthmatics. And a lot of times those who are steroid dependent, they're on oral steroids that may qualify for that, and they are all allergic asthmatics in that case. And like I said, there's only one. I think there's more coming out. Over the next few years, they're doing research on a few others, and I hope that will drive the price down a little bit and make it more affordable. But generally, this is stuff that requires a lot of prior authorization. We're talking several $1,000s per dose on these kind of medicines. So they're given subcutaneous. So a lot of times for our patients, if they're getting like immunotherapy, they're getting allergy injections. They can do that at the same time as us. So a lot of those patients end up just getting it at their allergist office too. But it's one, like immunotherapy, has to be given in the office, directly observed immediately afterward. Okay. And then I mentioned that Cromolyn and Indocromol, these are very, very old, very, very mild, not used very much anymore except by some of the real old dudes. So that's that. Intol and Tylate, and we're talking, been around for a long, long time. Just not super effective as far as potency goes. And they would be on the chart. They're going to be in those alternative therapies. Methylxanthines also more so reserved for the most severe asthmatics. I mentioned that this is what I was on as a kiddo. It requires monitoring of drug levels for therapeutic dosing. So not super convenient and definitely not preferred at any of the steps. And most of those that would be on that kind of thing are going to be step 6 kind of specialist management kind of thing. Okay, methylxanthines, the that group. Okay, questions about long-term controllers? Quick relief, the ones that you're most familiar with, probably. All right, albuterol, levalbuterol. Those are as needed to provide quick relief of symptoms. They tell that tight muscle that's like a boa constrictor around your airway to relax, to let your airway open up. And it does work quickly. They do relieve symptoms quickly, but they don't last very long. It provides relief for a couple of hours, 2 to 4 hours, and generally the symptoms are coming back. That's why you're receiving them in patients. Those are scheduled every 2 to 4 hours, depending upon their orders, but those are given pretty scheduled during exacerbations inpatient-wise. But they do provide quick relief, and there's lots of options for those as well. Inhaled is preferred, oral is not recommended, and it specifically says that in the guidelines we don't recommend oral. However, there is an albuterol syrup that you can still purchase, and there are some old dudes in the panhandle, I won't name any specific names, but who like to prescribe it, and then when I educate their patient, once they've referred them to me, give them all that, they like to call and chew me out about it. How dare you tell me I've been doing pediatrics for 40 years? about 4 years behind. So, the guidelines clearly state oral not recommended. One, there's a lot of systemic side effects with oral albuterol. Again, it's a syrup. You get a lot like Theophylline, you're very jittery. And it's not near as effective as inhaled therapy. Anticholinergics, ipratropium bromide Atrovent, is indicated for, certainly used in COPD on a regular basis. Those patients may have like a complement when they're taking albuterol and Atrovent combined together. Generally not recommended for outpatient use in pediatrics, however. They do use it as in the emergency room as adjunctive therapy with the albuterol, but not one that they use outpatient-wise. It's albuterol and albuterol. Those short-acting beta-2 agonists are the ones that are really using, in pediatrics. And then an oral steroid, like a burst, a short burst of oral steroids is the other quick relief we have. So those short-acting beta-2 agonists, I already talked about all that. Bronchodilates, this in simplest terms. Also effective at preventing exercise-induced bronchospasm. So it will tell the muscles, when I tell my patients, it'll tell the muscles to stay relaxed while you're exercising without clamping down. And usually pretty effective for a couple of hours. I'll tell the little ones, if you're in like a tournament and you're playing, 4 games today, I don't expect those 2 or 3 puffs that you took before the first game to be effective for the whole day. You may have to pre-treat again before each game. But generally, we'll provide protection for a couple of hours. So there's your examples: albuterol sulfate, levalbuterol, which is Xopenex. It is made with one of the isomers of albuterol, so it's a little less likely to cause the jitteriness, but a little bit more expensive, and a lot of times insurance companies don't like to pay for that unless they have a real good indication. So somebody with cardiac disease, somebody who has SVT or some significant cardiac disease generally can get it approved for. Some insurance companies don't care, they'll let you have it. But they're equally effective. One just may be a little less likely to make you jittery. And pure-buterol Maxair is the other one is an inhaler that is in limited availability now. I haven't seen it much lately at all. So short-acting beta agonists. Frequency of use is a big indicator of control. If this is somebody that carries it with them and they go through a whole 200 dose inhaler in a matter of a week or two, that's a red flag that something's wrong. If they're needing albuterol that frequently, they're needing their rescue inhaler that frequently, that's a big red flag. More than 1 canister a month is very poor control. Regularly scheduled use offers no benefit and is not recommended. So somebody who's well controlled, you don't say, okay, at home, you're gonna take your albuterol, morning, noon, and night. No, you're gonna take it as needed for symptoms. Now, during exacerbations, when you're sick in the hospital, certainly we may have it scheduled. But at home, that's an as-needed medicine. And for those who are needing it more than twice a week, that's that rule of 2, without me saying it that way. In general, that's kind of the rule of 2. So if you're needing a short-acting beta agonist more than twice a week, that's a good indication that you are not an intermittent asthmatic, but a persistent asthmatic, one who needs to be on an inhaled steroid. Makes sense? So transition to HFAs, fortunately this happened enough years ago that you may not be, you're so young, you may not be familiar with. There was at one point generic albuterol, which is nice and cheap. You can get one for like $11. But the HFA, the chemical propellant in it was CFC, which is damaging to the ozone layer. And in the event of saving the world, they phased out all the CFCs. So they all went to a new chemical propellant called hydrofluoroalkane, which is more ozone friendly. But when they did that, all the drug companies got a new NDC, a new patent essentially. So then everything's brand name again, and so now they're $50 instead of $11, which really stinks for people that can't afford it. The nebulized albuterol is still available generically and cheap, but when it comes to the spray kind, it's the chemical propellant that is new. And so a lot of patients had a lot of complaints about it at first because it smells different, tastes a little bit different. They're just not used to it, but this all happened in 2008, so most everybody's adjusted to the change by now, and they've not been available in the United States since that time, since 2008. So they are, and that just has the HFA is a little finer mist, so it's a little bit more likely to plug the canister. So sometimes they may have to wash their canister a little more, especially with some of them that have a little lower plume force, and the plume force is the strength where it blasts out. So sometimes they may have to wash this a little more, and they may find that it gets plugged a little bit more easily. But otherwise, the drug itself didn't change. It's just the chemical propellant that changed. And that happened for not just albuterol, but that happened for all the inhaled steroids as well, all inhaled therapies and the anticholinergics and everything else too. So for anticholinergics, those are also provide relief of acute bronchospasm. It helps to relax those smooth muscles in a similar way. It reduces the vagal tone. And like I said, those are primarily used in adults and COPD patients, but in pediatrics it is recommended for asthma in acute relief, especially in the emergency room. There we have it. Does not, the difference though too, the anticholinergics do not prevent exercise-induced bronchospasm. So if somebody has, and that's partially why in adults they use the combination one where it has both together. So they still get that benefit. Ipratropium, bromide, or Atrovent. And the nebulized version is called Duoneb. That's them together. There's that. And then systemic steroids, really briefly. That's just oral steroids. One, I'll tell you, they taste terrible. Doesn't matter what you put in, you'll mix it with. It tastes bad. The pills taste bad. The liquid tastes bad. We do use them for quick relief. It's what they're going to give you in the hospital. You're going to get oral or IV steroids, systemic steroids. During an exacerbation, it is what we use for home management of exacerbations. And those are short bursts. And the guidelines recommend 3 to 10 day bursts. And so everybody has kind of their own little way of doing it. Seems like the emergency rooms tend to like 5 days. We tend to treat for, we're seeing the sickest folks, so we tend to treat a little bit longer, more like 7. If you're leaving the hospital, we may put you on even a little longer course. But in general, 3 to 10 days is an acceptable duration according to the guidelines. And in adults, the dose is 40 to 60 milligrams, and in kids, it's 1 to 2 milligrams per kilogram, which means that gives you a little bit of a range of acceptable dosing. Okay? And I have all that on there. I said it before I even got to it. So those who are on long terms, certainly we do a lot more monitoring. Or those who've needed lots and lots of bursts, we want to look for those side effects of oral steroid use, like cataracts. They should be having annual eye exams. They get DEXA scans. These are the same kiddos that we end up sending to endocrinology for management as well. But they get the DEXA scans, looking at their bone density and monitoring of their growth, their adrenal function, and that kind of thing too. So that's all there. Systemic steroids. 1 to 2 milligrams per kilogram, 3 to 10 days in kids. 40 to 60 milligrams for 3 to 10 days in adults. And there they are. Not a one of them tastes better than the other. I wish I could say that they did. Pills, liquids, options. And there's really no benefit of an injection, injecting them as opposed to oral. I don't like my little asthma patients to think every time they come in sick that I'm going to give them a shot. Certainly injections available. If you, in the ER, some of the ER docs will tell me that they suspect they're really non-adherent and they wouldn't fill it and they wouldn't give it, so that's why they give them an injection. But certainly it's no better than the oral. Okay, when it comes to medications, dosing schedule should really be reviewed at each visit because it never fails that if you look at all this and you get overwhelmed, imagine your patient being no medical background or training at all. They need to be for sure that they know which is the controller, which is the quick relief, which one do I use as needed, which one do I use every day, and how do I use it again? Is it that one's morning and night, and this one is, so making sure that they really have a good understanding of their dosing schedule. Twice a day is what I would recommend for the controller therapies. If you recommend it to somebody 3 times, really anything, even antibiotics, if you're recommending it 3 or 4 times a day, the likelihood of adherence goes down significantly with every increase in the dose. So the inhaled steroids and when you're looking at the chart for comparative dosages on inhaled steroids, twice a day dosing is what would be recommended for all of those inhaled steroids. Asthma Court is one that's pretty weak, so you have to give a lot of puffs, and so they used to historically do that 2 puffs 4 times a day, which is really obnoxious. So part of the reason why it doesn't get used much anymore is there's other inhaled steroids that are more potent, you just don't have to take as many puffs. And then it should be provided in writing in the form of a written asthma action plan, that way they have something to look back at. Now, the technique is the biggest part. We're gonna do this and then we're gonna take a little potty break. The technique is the hugest part, and this is the biggest part of what I do, other than teaching them about what happens inside their little airways, teaching them how they work their inhalers, and all those little devices is really, really essential. It should be reviewed often, because even if you remember spending 20 minutes going over it all with them, if 3 months has gone by, they may have forgotten and they may have gotten into bad habits, so it should be reviewed regularly. And what I tell folks, if you're out in practice and you don't have the luxury of spending that kind of time with your patient, you get an asthma champion in your clinic, your nurse, your medical assistant, somebody that you've trained, that you know is familiar, or they've done training, gotten certified as an educator or something, to be able to do that so that you can step out and go, I've got to get into this next patient, but they need a review on how to use their inhaler, and you can send somebody in there to do that. So when it comes to meter dose inhalers, valve holding chambers, true or false, they're only necessary for younger kids. And it is false. We recommend holding chambers even for adults, and there's plenty of data to show that that's helpful. When you use an inhaler by itself, the plume force is such, it comes out at such a fast rate that if you put it directly in your mouth, a lot of it ends up just in your posterior pharynx, back of your throat, on your tongue, in your mouth. Well, it tastes bad, and that's not really what we're not treating your mouth. We really want you inhaling it into your lungs, and it's very difficult to spray something in your mouth and inhale what's in your mouth into your lungs. So the holding chamber serves just as that, as a place to hold the medicine, to allow you to really breathe it in instead of just spraying it into your throat. So this is an example of some gamma scintigraphy done where this is actual drug that lit up for them. And you can see, you can't tell as well on this picture, but on the actual printouts, you can see that there's even on the one where they're using it this way, there's drug even out like in the room, because the way they did that without a really good seal, drug makes it out in the room. And the way it's reversed, there's some deposited in their stomach there, although it's on the opposite side, it's because it's not a reverse picture like you're used to seeing. And you see some of it gets into their lungs. That nice tube there is that's not his trachea, that's his esophagus that it's stuck in. Whereas on the side where he's using the holding chamber, he gets more. We can get about 50% more drug into your lungs when you use a holding chamber. So we do recommend it, not just for little bitty kiddos, but really for everybody. Just keeping in mind that you'll need fewer puffs, you'll get more to your lungs, have fewer side effects if you use a holding chamber. So they're really appropriate for all ages, and especially like older people too that really have struggle with this technique. So your older patients might really benefit from it as well. So it's much faster. You could certainly give somebody a nebulizer and tell them, okay, that breathing treatment's going to take you 20 minutes. And if you're prescribing an inhaled steroid that way, and they're doing breathing treatments 20 minutes, 22 times a day, what's the likelihood they're going to keep that up long term if they don't have to? If they can do this, which takes just a couple minutes, much, much easier. And they come in many, many forms. I put a picture there even of somebody using just a Coke bottle, which is kind of a rudimentary version, but better than nothing, honestly. The respiratory therapists used to take just like a styrofoam cup. If they had a styrofoam cup, they'd cut a hole here and put the top part around their face and put it in there just to provide, essentially that would be a spacer as opposed to an actual valve holding chamber, but a spacer is better than nothing when it comes to that. It's better than actually putting it directly in your mouth. So there's lots of different options, and I'm going to show you how we do it. Yeah, I think I have videos that work too. So with the mask, for the littler folks, some of them are masks that are like detachable kind of masks, where you can have the mask on there or do the mouthpiece version. And then some of them, depending upon what company it is, this one is a mask that is just attached to the spacer. But the mask then goes around their mouth and their nose. And you put that dose into the holding chamber, and it's held there until they breathe it into their lungs. Now, anytime you use a meter dose inhaler, you've got to shake it first, because we're mixing the drug with the chemical propellant, so they say 5 to 10 seconds is sufficient for that. It goes in this end, that part around mouth and nose, 1 puff at a time into the holding chamber, and then with just normal tidal breaths, it takes them 6 tidal breaths to breathe that in. Okay? So it's pretty easy. Shake, shake, shake. It goes in this end, that and around our mouth and our nose, 1 puff, and then 6 breaths. I mean, kids, I always coach them on. 1, 2, 3, breathing, and as they're doing it, there's a little indicator valve. This is an older model that I melted at my house, so that's why it's my demonstrator. But the little valve, there's a little indicator valve in the newer models that will open and close there, makes it really easy for the parent to see. And depending upon which kind it is, most of them, you can see that valve opening and closing, and that's one way for them to count. And it is a one-way valve, so as they're blowing out, that air is going not back into the chamber. That chamber is still then sealed, so it's just a one-way in valve. Does that make sense? And then they would do the next puff. Once they're done with those 6 breaths, then they do the next puff. And your 6 breaths again. Easy, right? It seems easy for like an almost 40-year-old woman, but when they're little and they wiggle, it is a little bit more of a challenge. And I usually will, when they're little, I'll usually try to, if I can dispense one or have them bring it with them so that we can practice right there in the room, that's usually pretty helpful. I usually will position them on their lap, little toddlers especially. I will have them sit kind of sideways. Have the little one sit sideways and put their feet between their parents' legs. And you tuck this arm back here. And then you grab the other arm with this hand. And then you're using this to kind of wedge them into this position. And then even if they wiggle, you can follow them around. And I tell parents too, the longer you fight them and win the battle, the less they fight over time. Eventually they realize every day they're going to come out with this stupid spacer mask thingy and they're going to make me take these breaths. And I should just quit fighting. And eventually they do. And then sometimes even when they're 5, like mine, she was that day where she's like, I don't want to do it. And I just have to sit on her. Make it happen. So, but sitting on them, holding them down for that minute to 2 minutes it takes to do this is far easier than fighting them for 20 minutes for a breathing treatment. So I have a lot of parents that will say, oh, we can't do that. They don't like the mask. They don't like the mask. They don't like the way they won't like the mask for 20 minutes either. What you'll find that they tend to do, and I'm probably skipping ahead, but I have it on my mind, is instead of wearing the mask with the nebulizer, which they should when they're little, they may rig something to where they've blocked off the mouthpiece version of the nebulizer, then they just kind of blow this in their face. It's sort of like some kind of spa treatment, I think, for their skin. It's not an effective way at all. It's called blow-by therapy, and a lot of people do it. Right? A lot of small-town hospitals in the Panhandle still do it. Blow it in their face, and so it's nothing against the Panhandle. It's just once that guy retires, we're good. And so that blow-by is not only an ineffective way of getting into their lungs. It also could potentially be harmful. If you're administering inhaled steroids into their eyes, that's not a good thing either. So that's why I argue with them. If they say, oh no, we can't do this because they don't like the mask, well, if they're doing the nebulizer, they've got to do a mask anyway. So this is a much shorter time to have a mask on your face than a 20-minute breathing treatment. Now let's see if we can make the videos work. Oh, come on. Oh, because they're cute videos too. One, 2, 3, 4, 5, You see the little
6.
valve, the little blue
Good
valve?
job.
Yay!
Yay! Now Piggy's turn. Oh, Piggy.
So this one, the little blue valve, and that's one of my short people at my house. The little blue valve there, you can see it using really easily that way. So that was just one puff, but that was pretty quick, right? Pretty doable. And she's not a very agreeable child, and she does it on a regular basis. So it's doable. And that's one thing that helps is to have said that it can be done, and just reinforce to them, and lots of other families do it, yes. They will fight you on a lot of things in life. They won't want you to brush their teeth. But by golly, you better be holding them down and brushing their teeth, or you're going to be really sorry. So the ones who are non-adherent don't want to do that. A lot of times their mouth's full of silver too, I find. There tends to be a pattern there. They don't make their kids do much of anything. So that becomes a bit of a challenge there. True or false? They're not made for use in infants. That's VHC is short for valve holding chamber. Not made for use in infants. Oh, sure they are. That's not my infant, but my friend's infant. Yeah, the masks come really small too. And they come in little nice cutesy little sizers. You can have a tiny or a medium or a big, and it's like the three little bears. This mask is too big, that mask is too small, but this yellow one is just right. So don't fight your mommy when she comes at you with it. So yes, they come in different sizes too. And so even the little bitty, tiny, straight out of the NICU preemies can do this. It's much easier and faster, makes life a lot easier too. And that position is kind of what we usually do for, what I usually would do for a little bitty one too, is it gets you a good angle where you can see what you're doing. Hold them still. So there's with the mouthpiece, so usually by 7, 8, 9, 10, kind of depending upon their developmental level. Most of the time then, you can transition them to just the mouthpiece only without the mask. And it is a preferred method once they're able to do it that way, and so this is what our adolescents, adults do, and little kids. You shake, 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 just like before. It goes here. And it actually is ideal. We just do the tidal breaths with the little ones with the mask, but it's ideal to do a nice, slow, controlled breath. So once they're old enough that you, as you're coaching them and teaching them, they can do that. This is a preferred method. Shake, 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 here. And I teach them with inhaled medicine. You always want to start with empty lungs. If you're at half capacity, doing a slow, controlled breath is much more challenging. If you empty out, it's much easier to do a nice, slow, controlled breath. So we shake first, we empty out. In your mouth, 1 puff at a time in the chamber, and a slow, deep breath, and they say over 3 to 5 seconds, and I usually teach them to shoot for 5, that way if you're a little too fast, you're still in good shape. So you empty out, 1 puff, slow, deep breath, and hold it. Then you hold your breath for 5 to 10 seconds, and so I have them count, and breathe out through your nose. You can. Okay, pretty easy. Then you come back with the next puff. You do. What folks tend to do as far as mistakes with either way is they try to they know their dose is 2 puffs and they just load it up with both. And really just 1 puff at a time. And slow breath here, 6 tidal breaths. Pretty easy, right?
With the masks as a child, I know I used them when I was younger,
Huh?
but my mom stopped using it, obviously, just people don't listen. But I was always like sucking it in instead of inhaling it, and so it was getting all in my mouth, and so that's why we just went to she could actually make me inhale that way. Is that, I mean, with the mask, is it common where someone's just like sucking it in, it's like getting on their face instead of a true inhalation of the medication?
So if
You get what I'm asking?
yeah, but if you get a good seal with that mask, and if you fight them long enough, they're going to be breathing and not just like fluffing their cheeks out. So I mean, it definitely takes some finesse and practice when you're fighting with them initially. But certainly it's preferred in a little bitty one. It's preferred to do mask, holding chamber, than to do a spray like this. Anyway, yeah, but do a lot of parents say that very same thing? Yes, and unfortunately the science just doesn't support that. When they look at it in studies, this method is far preferred, and you just get a lot more into the lungs that way. And it's just normal tidal breath. It doesn't have to be big. It's just normal tidal breath. So I'll tell those moms, like, if they're coughing, they're having a flare up in the middle of the night, and you're going in there to get puffed, they don't even have to be awake. If you get a good seal with the mask and you see the valve opening and closing, they're breathing, they're taking tidal breaths. Keep that mask there for 6 tidal breaths. And some moms choose to always do it that way, so they don't have to die. So that there's no that. And I think I have a cutie demonstrating. This is a steroid-dependent kiddo, thus his fluffy cheeks, so forgive him for that. Oral steroid-dependent, I should say. I was a little nervous, but So the Vivadress inhaler alone, certainly not recommended, but if you're going to do it by itself, it is better, so I don't move myself up today, it is better to do an open mouth technique than to do a closed mouth technique. And I know that seems crazy. And if you saw somebody like, you know, on an airplane, like, you'd be like, what's that weird? Why did they not just put it in their mouth? But actually an open mouth technique is preferred over a closed mouth technique, believe it or not. But it's pretty difficult to do. One, I have pretty bad aim, so I tend to spray myself, spray my cheeks, spray my eyes, whatever it is. I actually prefer that you hold it 2 finger breaths, like distance from your mouth if you're gonna do it without a holding chamber, and that's to allow this to provide some of this space between it. You empty out, and then as you're inhaling, that's when you actuate it. That way you've already started your inhalation, and you actuate, and you're actually breathing instead of spray, then breathe like you do with the holding chamber. You actually start your breath, actuate, continue your breath. I'll try to demonstrate it, but I'm terrible at it. I use this one right here like this for me because I'm not very good at it. So you empty out. Like a lot on my front teeth. Hold it, same way, hold it for 5 to 10 seconds. Breathe out through your nose. They actually, in a group of pulmonologists, they passed around an inhaler looking, and they did kind of a little mini trial looking to see. And in a room of some 50 pulmonologists, I think only 1 or 2 were able to really demonstrate a good job with the open mouth technique. Those weren't all just pediatric pulmonologists either. Convince the grown-up doctors that it's a good idea to use a holding chamber. It's just much easier. Now, if I have folks, I certainly do have some adolescents that it doesn't matter how much I argue with them, they will not carry it because it's big and it's bulky and it's embarrassing. I'm not going to take that. There are some more compact spacers, and one of those pictures showed some of them. There's one that actually the canister will store inside the spacer itself, which makes it much more compact. So there's some of those options. Also just corrugated tubing, and this is what we use in our pulmonary function lab. It provides space. That's not about holding chamber, but it does at least provide space, which is better than nothing. So some of my adolescents in this is dirt cheap. So some of my adolescents may do that instead, but at least then it's putting a little bit of space there and slowing those particles down a bit. Crazy, right? You're going to get out there and you're going to see a ton of people prescribing inhalers and not using spacers, right? Is it the end of the world? No, but is it the best method? No, and is there a good likelihood that it may not work as well and they are coming back for follow-up and yeah, I tried, but now I got thrush in my mouth, or other risk factors of using inhaled steroids, but using a spacer will reduce that risk. If I didn't mention it during the inhaled steroid discussion, when you're taking an inhaled steroid, you should always rinse your mouth and brush your teeth afterward. Because if you leave that inhaled steroid in your mouth, certainly you're increasing your risk for thrush. Using a holding chamber will help to reduce that risk, but we do still recommend rinsing your mouth and brushing your teeth. And then there's the closed mouth technique, which you can find core technique on any movie or TV show. And never consult with an asthma educator when they do that. So as far as meter dose inhaler valve holding chamber, if it becomes clogged and it won't spray, well then obviously the holder part needs to be cleaned. The canister itself should never be submerged in water. We used to do a float test to see is it empty, is it full? We definitely do not recommend the flow test because it will actually damage the valve. So not recommended. The best way to know if it's empty is to look at the dose counter. And most of the inhalers these days have dose counters on them so that you know if they're empty. I brought some that I know are empty. As a demonstration though, this one's on 000. I have a witness or two, and it's on 000, but it will continue to spray. About 20, sometimes 30 times. So what does that tell you for a patient who doesn't have a dose counter? If they're using an inhaler without a dose counter, the last 20 or 30 times they may not be getting active drug, which is a big reason why they've gone to dose counters for most of the controller therapy. There's only one fast-acting inhaler now that doesn't have a dose counter, and that's Proventil. I don't have anything against them, and they say they're putting a dose counter on there soon, but I tend to not prescribe it for that reason, because if it's their rescue medicine, and they don't remember how long they've had it or how many times they've puffed it and all that, it comes with 200, so it may be one that they've had, for months, and they go to use it and it's near the end, and it may not work because maybe they're actually out and they just don't know it. So the dose counter is the best way to know. Otherwise, they can keep track every time you puff it and mark it. For a controller medicine that you take on a scheduled basis, it's really easy to know when your inhaler is going to be empty. If it comes with 120 puffs, You take 2 puffs 2 times a day, that's 4 puffs a day for 30 days, 120. So you know every 30 days you need to replace your controller. But when it comes to your quick relief medicine, that is a different story because you use it kind of sporadically. So keeping track of it with little hash marks is what I used to recommend before there were dose counters. Dose counters are a much easier way to do things now. So, let's skip anything else that was important. Cleaning it. The spacers, that most of the manufacturers recommend that washing them once a week in warm soapy water and then just drip dry. The newer ones though are dishwasher safe also, so especially little kids that are snotty nosed and sick all the time. So throw it. If it's dishwasher safe, throw it in the dishwasher and sterilize it that way. I don't recommend the baby bottle sterilizer, which is how that one got worked at one point in its life. But the manufacturer instructions that come with the holding chambers will give those specific instructions on how to clean them. Okay, float test not recommended. We're in the home stretch of the meds, folks. We got 5 minutes to bathroom break. That's good, right? Dry powder inhalers. So we talked about meter dose inhalers. Questions about those? You get fast-acting and meter dose inhaler. You get long-acting controller medicines that way. Use holding chambers, all that. Now, dry powder is the other type of inhaler, and it actually is, the drug companies that make both say that their drug gets delivered better to the lungs and the ones that use a dry powder. So if they're able to, if a patient is able to use a dry powder inhaler old enough and they can demonstrate good technique, it is really the preferred method. There's lots of different dry powder devices. Probably the one that you're most familiar with is a discus. This discus is a Glaxo device, and so there's several different drugs that are available in discus form, both inhaled steroids and combination inhaled steroids. Long-acting beta agonists are available this way. Though these dry powder devices, they load in a different way, but the way that you actually take the inhalation is the same. It's just a different way to load for each one. But they're all breath actuated, so nothing is spraying out, which is why you don't have to worry about a holding chamber to slow the particles down and trap them so you can breathe them in, because your breath is really what's sucking the medicine into your lungs. Generally not indicated in really little ones. If they're not old enough to do spirometry and they can't use a mouthpiece with their thing, a dry powder is not a good idea for them. And each one is really specific, so I'll show you. This is the purple one there that's Advair, which is fluticasone, Flovent, and salmeterol, Ceravent combined. But that discus, we call it, it's actually an AccuHaler, but we call it a discus. And I teach them to hold it like a hamburger, parallel to the floor. And they open it up and they click that back. And all that does is that loads the dose. It moves the medicine into a place where that powder is there sitting ready to be inhaled. So the reason we tell them to hold it parallel to the floor is that if you've loaded the dose and you're doing this, you're gonna lose some of that dose. That powder may come out. And in fact, if you have a patient that uses like this and then you show they open it up and there's a whole bunch of powder all around, that powder should have been in their lungs. And if it's all stuck around here around the mouthpiece, I would suspect they're not doing a good job with their technique and they should go back to a spray inhaler time. So with this, we hold it like a hamburger, open it and click it. And then with all the dry powders, you always just like with the meter dose inhaler with the mouthpiece spacer, you always want to empty your lungs out first. Empty them out so you can fill them up with medicine. So you empty your lungs out, and then in your mouth, and a really strong, deep breath. And these powder medicines, some of them you can taste a little bit. They'll put a little bit of lactose or something in there for you to be able to taste it. It's lactose powder, but some of them will put a little bit of water so you can kind of taste it. But a lot of them, they don't feel anything. So when you're teaching them to use it, making sure that you teach good technique is important, so that they feel confident that, yes, okay, I know what I'm doing. And even though I don't feel anything, I'm getting this medicine to my lungs. So open, click, empty, deep breath, hold it, 5 to 10 seconds, out through your nose. And then with each different device, and then especially with dry powders, it's important that they're rinsing their mouth, they're brushing their teeth after they use it if it's a steroid. Then there's several other devices. The Pulmicort is available like this in what they now call a FlexHaler. To train patients on it, they make little whistle trainers so that if they suck in at the appropriate inspiratory flow, the rate at which they need to be able to inhale that powder, it'll whistle. So the little whistle trainers are available for several of the devices to show that, yes, you sucked it in fast enough. If you sucked it in enough to make this whistle, we know that the drug will get to your lungs. So it's helpful, especially like I said, when they're not tasting or feeling anything, that they know, okay, yes, I'm getting it. So this one, hold it like a whistle, turn and click, empty your lungs out. In your mouth, quick deep breath and hold it. And it's real fun when you're teaching little ones, because they love it. Hold it for 5 to 10 seconds, out through your nose. And like I said, there's several devices that are similar to that. This one is almost the same, except that the dose loads as you remove the cap. So like I said, for each one, it's just the way that you load the dose that's a little bit different. But essentially the dry powders are all the same. You empty your lungs out, quick deep breath, firm deep breath, hold it for 5 to 10 seconds. Breathe out, rinse your mouth, refresh your teeth after you use it. Okay, so that's dry powders. Cool. Twist Taylor I showed you. Nebulizers, kind of a soapbox issue for me. A lot of people really think that nebulizers work better. There's plenty of data to show that they don't work better. They do take more time. They do work equally as well, but because they take more time, they're not as convenient. There are certainly some drugs, and especially in CF care, that they don't have a choice but to use a nebulizer, but with asthma care, there's always an alternative that's faster. So we tend to not use nebulizers much in kids, if we can help it. Both are available in nebulized form. It's no more effective, it just takes more time. But you should be reviewing the technique. It should be a mask like that little girl's wearing that stays on her face and not blow by. I already told you the answer to that one. If they're uncooperative with the mask, you can just blow it in their face, and the answer is no. That shows the whole little mechanism. What I'll show you there is what a lot of times they'll do is they'll just block off the mouthpiece, and then everything is coming out this tube, and then they just blow it in their face, which is not recommended at all. But with the nebulizer, it's important that they're cleaning it, and they're replacing their nebulizer cup and all that mechanism like they should. One other thing I usually bring is this handy dandy little pacifier that people will use. And this essentially delivers blow-by therapy too, because what they're doing is that attaches onto the mouthpiece instead of the mouthpiece, and then it's blowing into their nose essentially. So some people think, oh, it's the greatest thing, it's got a little pacifier adapter, but that's essentially blow-by therapy too. It really should be a mask. Now, if it was a pacifier inside of a mask, I'd feel better about it, but it's not, it's just like this, so that is not recommended either. Okay, we're gonna take a break. We're gonna talk asthma self-management education, asthma action plans, and use spirometry. How long do you guys usually break?